Olá, pessoal, boa noite. Sejam bem-vindos a mais um Debatendo com a APECIH, hoje num formato um pouco diferente, né, no formato híbrido. Nós estamos muito felizes por todos vocês presentes aqui no Hospital Samaritano, né, o pessoal conseguiu vir presencialmente, e desde já nós queremos agradecer também todos os que estão conectados online. Hoje o nosso Debatendo ele traz um tema bastante diferente e importante, né? Então a gente vai falar sobre a ciência da implementação, utilizada especialmente para prevenção e controle das IRAS. Eu não me apresentei, mas eu sou Lígia Abraão, eu sou coordenadora de pesquisa em enfermagem e práticas assistenciais aqui no Hospital Samaritano, e também faço parte da diretoria da APECIH, tá? Eu quero agradecer mais uma vez a todos os presentes e também o nosso patrocinador exclusivo, a CNPH, e quero agradecer também à diretoria do Hospital Samaritano pelo apoio, né, pela oportunidade de estarmos conduzindo esse evento presencialmente aqui no hospital. Então, eu quero dar algumas orientações para vocês que estão online, para os que estão presencialmente também. Se vocês tiverem necessidade de utilizar a tradução, cliquem no globinho, aí que aparece na parte inferior da tela, e vocês podem selecionar o idioma no qual vocês desejam ouvir a apresentação, tudo bem? Então, sem mais delongas, eu gostaria de... Deixa eu só me acertar aqui com os papéis. Certo, vamos lá. Então, hoje a gente vai falar sobre estratégia inovadora para serviços de controle de infecção hospitalar, o uso da ciência da implementação para prevenção e controle das infecções relacionadas à assistência em saúde. Então, para isso, eu quero apresentar a vocês o professor Stephen. O Stephen, ele é professor de gerenciamento dos serviços de saúde na Escola de Negócios da Universidade de Nottingham. Ele tem estudado como a saúde e o social eles podem melhorar por meio da inovação. Então, a implementação de novos tratamentos e serviços é um dos temas principais de sua linha de pesquisa. O professor Stephen ele está atualmente envolvido em cerca de 10 milhões de pounds em bolsas que foram cedidas, né, bolsas para suporte à pesquisa do NIS, ou NHS, e sua bagagem acadêmica ela é em sociologia, e ele trabalhou também como gerente do NHS antes de se tornar acadêmico. E também para nos apoiar no debate, nós teremos a professora Ana Sara Levin. A professora Ana Sara ela é titular do Departamento de Moléstias Infecciosas e Parasitárias da Faculdade de Medicina da USP, é presidente da Comissão de Controle de Infecção Hospitalar do Hospital das Clínicas e coordenadora do Grupo de Controle de Infecção Hospitalar do Hospital das Clínicas, também da USP. Na sequência, teremos também nos apoiando na discussão a doutora Maria Luísa Moura, que está chegando para conectar com a gente. A Maria Luísa é infectologista pelo Hospital das Clínicas, é doutora em doenças infecciosas e parasitárias, e também é médica assistente da Subcomissão de Controle de Infecção Hospitalar do Hospital das Clínicas e gerente médica do Hospital Vila Nova Star. E na condução desse evento, em conjunto comigo, está a enfermeira Fabiana Vasques, que é enfermeira do Serviço de Controle de Infecção do Hospital 9 de Julho. A Fabi, que assim eu chamo carinhosamente, é especialista em controle de infecção e também em gestão da qualidade. Então, eu passo agora a palavra para o professor Stephen. Quero agradecer mais uma vez, Stephen, por tê-lo aqui no Brasil, por tê-lo especialmente nesse evento da APECIH. Todos nós estamos ansiosos por ouvir sobre ciência da implementação, e a gente sabe que cada vez mais a gente precisa de estratégias inovadoras para a prevenção e controle das infecções relacionadas à saúde. Welcome, Stephen.
Olá, obrigado pela convite. Não falo português bem, devo falar inglês. Nice to meet you all, and hello to all of the people who are online. I'm going to talk a little bit about implementation, so I'll move straight on. So I am sure that everybody is familiar with the cycle of evidence-based practice. It's now a well-established approach. It's maybe 35 years since the original paper that proposed this approach, and it's something we all aspire to. However, we know that for all of our aspirations and work towards evidence-based practice, we don't always accomplish it as straightforwardly as we might. I'm going to talk for a few minutes about why that is, and then to talk about what we might do about it. So, quotation, maybe you're familiar with it, but I just point to the figure of between 17 and 20 years to get clinical innovations into routine practice. And that is 17 years after the publication of a definitive randomized controlled trial. I'm happy to tell you that I am 60 this year. So in 17 years' time, I will be 77. I can't wait that long. I'm going to need those things. So why is it so slow? Why does it take so long? Healthcare is conservative, and that's for good reasons, because people's lives or their health could depend on things that you're all involved in doing day to day. And so every new treatment or program or new technology needs to be both safe and effective. And further, how clinicians of all professional groups work has evolved over time into some very complex systems. Our practice, our processes, and our cultures are very, very complex. And when I say to my colleagues in the business school that I spend my time studying an organization with 1 million employees, they say, yeah, that's complicated. It's bigger than any corporation. And again, we know that changing one small thing can have unexpected and sometimes catastrophic consequences. So that's why we're cautious. And the little picture there is, I realize it's a metaphor in English. It's called a house of cards. If you take away one card, the whole house falls down. And what we do is sometimes. And my brilliant colleague, Professor Trish Greenhalgh, who's at Oxford, wrote this. And this is a further explanation why it takes so long to do new things. And Trish tells us that people are not passive recipients of innovation. They experiment with them, they evaluate them, they mean things to people, they have feelings about them. We worry, we complain, we work around things. And there's a whole talk on how we work around the processes that we have. We modify them, we try to improve them, we redesign them. The process of implementation is not straightforward, and it's a profoundly social process. It's a phenomenon within a social world that we're all part of. We're all participants in that social world. Why does this matter? And this is a quote from the journal Biomed Central Implementation Science. It's the leading journal in my field and a great place to start if you want to learn more about what we do. And they tell us it's strategically important because it places an invisible ceiling on the potential for research. I know that my colleagues in the University of Nottingham and elsewhere in the UK do great research, and they are brilliant and hard-working people who devise new things which can reduce suffering, improve people's health, improve people's well-being, and we're not getting them to the people who could benefit from it. So we need to understand why it's so difficult, why it takes so long, and then we can start to do new things better and faster. So implementation research, and this is the official definition again from BMC Implementation Science. Just pick out a couple of key phrases. Scientific study. It's a social science. It's not a natural science. So it's not like physics or chemistry. It's more like anthropology, sociology, social psychology, and we draw on those disciplines to promote the systematic uptake. So we don't want implementation to be random or patchy. We want it to become routine. And in this context, it includes the study of influences on patient behavior, healthcare professional behavior, and organizational behavior in entirely healthcare or population settings. So that gives you a notion of what the discipline is about. I've also added the quote from, again, another British colleague, Carl May, who is in fact a very distinguished implementation researcher, but he's typically British and he likes a joke. And someone asked him to define implementation science, and he said, "Oh, it's a made-up discipline, an invented discipline." We love not to take things seriously, and Carl is typical of that. But his work is very serious, and yeah, recommend it to you. So the first thing that I want to do is tell you about an implementation study that I did and with my colleagues in Nottingham and elsewhere regionally. And I'm mindful that it's quite a different field from the one you're used to. I'm using it as an example to try and tell you why and how we do this research and some of the things we learned. And I need to give a big credit to my colleague who has just become professor at this Gordon. So I need to change that. Liz led a randomized controlled trial which showed that an intervention for older people reduces falls. You all know that falls are not a good thing for older people. And this intervention is an exercise class. It's a very simple intervention, but the trial shows that it works really well. And I have done the class myself. Managers in the healthcare systems, primary care doctors. We ran a community of practice with the trainers. We observed the classes, and we also measured the outcomes to see if the intervention was still getting the same results when it wasn't in a trial, when it was being run in, I think it was about 15 different places, and we just had to let it happen, which was a bit anxious to begin with, but it was the good thing to do. So these are the posters that we use to recruit the participants, and because it wasn't a trial, we wanted to make it realistic. We didn't specify recruitment criteria
for the participants. We said, if you're over 60, come along. And we didn't, because we wanted to know what would happen in the real world. It wasn't like a trial where you select your sample very carefully. We actually ended up with a sample who were slightly less healthy than the trial sample, and it still worked. We just said, come along. Whoever wants to come can come. We made a small charge to £2. It's not a massive amount of money. It's less than a cup of coffee to come to the class. What did we learn from doing implementation research? We needed to let the trainers have some freedom in how they ran the class. And, you know, we'd done a trial, we had a protocol for how the class should run, but we found we needed to give people some flexibility if it was going to happen in the real world. We needed a quality assurance process. So we needed to be confident that the class was being delivered properly. We learned a lot about what persuades participants to come and what persuades the local government to pay for the class. And perhaps unsurprisingly, the epidemiologists in public health wanted to see the randomized controlled trial data, and they wanted the health economics study. But the local politicians weren't interested in any of that. They didn't want to see tables of figures and equations, but they did like the videos of happy old people doing their exercise class. And then we did little interviews. They said, we love our class. We love Dave, our instructor. That is what sold it to the politicians. So different audiences need different stories. And people needed to know that it works locally. And that turned out to be surprisingly important. We thought we had done science and said, this will work anywhere. And it was almost like people didn't believe us. They said, oh, but will it work in Kettleston? It's a village. It does, but people need to know that and be confident of it. So we are now, our next research project with Falls is to implement the class, the exercise class, nationally. And that study is going on as we speak, and we're rolling it out to the whole of England. Yeah, we're learning a lot. It's not simple, but we're still learning more about how to scale up and spread to really different parts of the country, to some big cities, to some quite poor neighborhoods, to very ethnically diverse neighborhoods. But we're also studying somewhere that's very rural and some seacoast communities. And the implementation is not the same everywhere, but the study's going really well. We're very happy. So that was a success. It's out there, you know, if you're in England, you can even come with me and go to a class if you want to see it happening. It's real, it's happening. Let me tell you about a failed implementation as well, because we know why the exercise class worked, but sometimes things don't work. And the credit here to my colleague, Professor Tanner, also at the University of Nottingham. She's in the School of Nursing. And I thought I should give an example that was a bit more relevant to the people in the room. And Judith studied a care bundle that is intended to prevent surgical site infection. So I don't need to tell this room about surgical site infections. You're the experts. This was a national care bundle based on good scientific evidence. So again, the science for each intervention in the bundle was strong. Good quality trials, systematic reviews, those kinds of things. And Judith and her team collected data in several hospitals for 6 months. They did have some commercial support for some of the products, so I need to mention that. And they had a project nurse to help implement it. It was not a success. If you look carefully at the data which compares the baseline to the care bundle, there's actually very little difference. So Judith and her team went to a lot of effort to implement a care bundle. It's, again, composed of well-supported interventions that have all been shown to be effective in preventing surgical site infections, but it didn't. And they gave it 6 months. And there's several thousand patients in the study, and didn't make it worse, so I suppose that's something, but it certainly didn't improve things as they imagined it would. But because Judith and her team are great researchers, they turned this into an opportunity and said, what can we learn about implementation? So I'm just going to share with you some of their findings. Yeah, you can see the adherence to the interventions, which is not great. Okay, so this slide tells us what went wrong, and these are some of the things that Judith and her team found when they went and interviewed the various participants in the study. They realized that they hadn't found everybody who they needed to engage. And this is quite a common problem. Healthcare is complicated. There's lots and lots of people involved. Very few of us know everyone and everything. And it's, there were issues that came up, and the team was saying, I didn't even know they were involved. Or they'd even say, who are those people? What do they do? Hospital's a big place, 10,000 employees. So can't anybody. The evidence for the interventions was strong, but it didn't persuade all of the people involved. And it's one of those kind of strange phenomena. If you say to people, do you practice in an evidence-based way? They say, oh, yes. And then when you look at what they do, it's not so simple. One of the things they found is there were 7 interventions in the bundle. And some people said, oh, it's too many. It's too difficult. We've got too much to do. I look at that list and I go, oh, these patients, I know I've got to do this as well. So there did seem to be an issue around too many interventions. And I know Judith has said maybe we'd have been better to have the 3 with the strongest evidence and maybe not bother with the others. It might have been more effective. It couldn't be sustained once the extra money from the project stopped. The bundle stopped. People changed the bundle interventions. Scientifically based, randomized controlled trials, people still did them their own way. And they realized that their approach had been to start at the top with the senior people in surgery, which seems like the obvious thing to do. You've got to engage them. but the team also think that they could have done more from the bottom up, engaging with more and more junior staff. And again, this is an expert team who know that world well. And one of the things that they said was, we didn't realise quite how complicated it was. And another study that I myself have been did with Professor Tanner, with Judith, was as part of it, we actually physically followed a patient, a surgical patient, from the moment they arrived at the front door of the hospital until they were safely in bed post-operatively on the surgical ward. And we mapped the process carefully. And then we talked to all of the people who were involved in the process. And it was surprising how little they knew about the other bits of the process. They knew their bit, but they didn't know very much about what went on elsewhere in the institution. We were, one of our co-investigators was an anaesthetist, and he was surprised too. So often people don't know as much as you think they do. So Jude's prescription, and I think this is sound advice, and very much found it from an implementation study. Identify the problem and make sure everybody agrees it's the same problem. And again, it's surprising how much people can differ. Identify all the stakeholders. And even if, like me, you've done the job for 35 years, you don't know everybody. Engage them and engage in a way that works for them. Manageable number of interventions, yes, with a solid evidence base. And interventions that work within your hospital, your service. And it may be a great intervention, but it might not work where you are. So understanding the problem is a necessary condition for solving it. And this is why I think implementation research can help. And this is the kind of work that I'm involved in, is identifying some of the problems and the barriers by using the existing literature. Quite a lot is known, and by using the sorts of theories and models that we have within the discipline. Happy to talk more about them. Understanding the problem fully, and approaches like root cause analysis might be helpful. Again, we get involved with designing solutions, particularly with ideas like co-production or co-creation. As I say, we are learning about scaling up and spreading, which is a different way of working. And we've also got involved with policy change. So I really do think that research and some of the approaches that we use can help provide practical solutions to implementation problems. Thank you for listening. I'm always happy to talk to anyone. I've put my email on the slides if you want to give me an email. If you want to talk, we might have to do it in English, because my Portuguese, as you heard, my Portuguese is very limited. But I'm always happy to chat to people. Just send me an email and say, I came to your talk in Sao Paulo, and I wondered about, I'll try and answer you. But sometimes the answer is, I don't know either. Sometimes the answer is, yeah, it's really difficult, isn't it? So thanks very much for listening, and happy to talk further to all of you. Obrigado.
Muito obrigada, Stephen, pela excelente apresentação. Quero lembrar o pessoal que está assistindo online que as perguntas poderão ser feitas via chat. E aqui, quem está presencialmente, a gente tem a possibilidade de contar com as moderadoras e fazer as perguntas ao vivo. Então, eu quero convidar para compor a mesa a professora Ana Sara Levin e a doutora Maria Luísa Moura. Por favor, juntem-se ao Stephen.
So thank you so much for this topic. I think I'm supposed to falar português, é isso? Tem perguntas para...
Por enquanto, não.
Por enquanto, não. Você tem pergunta?
Pode falar.
Como é que a gente lida com frustração? Porque eu acho que uma das grandes questões de quem faz a implementação é: você acha que você encontrou a solução, você faz a intervenção, e aí tem a frustração de quem... É uma profissão muito frustrante para muita gente. Muita gente não dura muito tempo na profissão por isso.
Okay, yeah, I share your frustration, and I guess one of the things I would say is people in all disciplines, in all clinical areas, and as far as I can tell, in all countries, feel the same way. It's difficult to do new things. I guess what I would offer is that a thoughtful, a considered approach to implementation can pay dividends, particularly the falls prevention exercise, which has worked really well, and we've now got that happening in a lot of places. It's taken a long time, it's taken a lot of work, but I think it's because we've gone about it in a systematic way. And, you know, when you try to go from local to regional to national, new worlds of frustration open up. And one of the things that we've found that we didn't think about before is we got involved in local politics, and you know there are people, politicians who are in favour of it, and others say, "Oh, what a waste of money! Making old people do exercise, what good is that?" So I absolutely share your frustration. I think I'm offering an approach that can help, but I said to a group of people earlier today, I am not Harry Potter. There is no magic solution. I am English, but
Bom, eu acho que nós, como profissionais de saúde, né, quando a gente vai fazer implementações de qualquer intervenção, eu acho que a nossa grande dificuldade é ter um grande conhecimento técnico, né, de evidências científicas, mas acho que, como você disse, é uma ciência social, né, assim, e é algo que acho que a gente não tem uma formação adequada, talvez ainda, nesse sentido de entender a parte social da ciência da implementação. Você acha que seria importante a gente colocar isso já na formação dos profissionais de saúde?
It would be good, but I am mindful that the courses, the curricula are already very long and very crowded, so we might need to stop doing something else. Don't ask me what. I think that social science is actually intuitively quite easy to grasp. And one of the things I know theoretically is that we are all social scientists. We all understand the social world because we exist in it every day. We have ideas about it. What I have just spent a bit more time on it, perhaps, and thought a little bit more and done some reading. generally find that when we start to talk to healthcare professionals about these ideas, it's usually they're quite comfortable with them. And they often say, oh, do you know, I've always wondered why, but that's what it's called, that's what it is. So what's nice for me is that generally my clinical colleagues are quite receptive to the ideas because they can see a value in them. Sometimes only to explain, but sometimes to help. So I think we can all be implementation researchers. You don't have to have a PhD, but maybe be interested and think about it. You know, one of the things I know from my own PhD students is that healthcare professionals are universally good at the practical aspects of doing research. Sometimes they find the theory a bit new and a bit strange, but by comparison with people who've come straight out of an academic program, they understand the real world and they understand how to make things happen practically. And so I don't think it's that hard to do. What's hard is finding the time and the resources to devote to it. And yeah, I think that's much more. But it's not serious. And academics always make things sound difficult. But you know, I point you to Karl May's quote where he said, "Oh, it's a made-up discipline."
Tem uma pergunta aqui da Cláudia Silvia. No projeto apresentado para reduzir a infecção do sítio cirúrgico, foram envolvidos também a liderança do centro cirúrgico, cirurgiões e alta liderança da instituição? As equipes de anestesia também se envolveram? Alguma ação foi realizada para que paciente e família se envolvessem?
Really good question, by the way. We did involve all groups of clinical staff, including the anaesthetists. What we didn't do was involve patients. We now realise that was a mistake. And certainly Judith Tanner's work and some of the things where we've been working together, we've now got patients involved much more extensively and early in the study. So Judith has just got a large grant from the National Institute for Health Research, and a named and paid researcher on the study is a patient. And he's leading those aspects of the work. And she says he's absolutely terrific to work with because he sees things differently from the researchers and from the clinicians. And he is great at engaging other patients because they say he's an ordinary person like us. He's not a doctor or a nurse or a researcher with a PhD, somebody who sounds important. We're not, but sometimes people think that. And so, yeah, I think that was a shortcoming of the original study, and the team are trying to do things differently now. Yeah, great question.
É uma pergunta junto com uma reflexão. Acho que nós, né, controladores de infecção, a gente vem numa era de uso extensivo das tecnologias para a prevenção das infecções relacionadas à assistência em saúde. E a gente sempre chega, acho que na maioria dos cenários, né, depois de ter implementado uma série de tecnologias, a gente chega num ponto que a gente não consegue evoluir mais. E às vezes a gente se vê, né, em diversas situações pensando, tá, e agora? O que está faltando, né? Já implementei todas as tecnologias possíveis e ainda assim tem dificuldade, existe a dificuldade de melhorar os resultados em relação às infecções. Aí eu queria saber a tua opinião, Stephen, se você acha que nós, primeiro, é chegado o momento de se preocupar mais com as pessoas, né, gente? Lógico, a tecnologia é um adjuvante, mas a gente precisa olhar para as pessoas, e se é o momento da gente pensar também em ser mais objetivos, né? As pessoas nem sempre enxergam o problema da forma como a gente enxerga, então eu queria saber a tua opinião a respeito disso, se é necessário ser mais objetivo para atingir melhores resultados e também para fazer com que as pessoas concordem e entendam melhor o problema.
Huge question. I wrote a whole PhD about that question. So what can be problematic is technologies, however effective and scientifically based they are, where the people who are using them have no stake, no involvement, and that can that can cause some substantial problems, and it was certainly the case in my own doctoral research. It's not always easy or even possible, but what I would advocate is more of a kind of co-design, co-creation approach, where rather than saying to people, okay, use this thing, talk to them about how they work. And again, one of the things that people don't always know is how people really do their own work. We think we know, and sometimes if you ask people, especially in a public setting like this way, and then when the doors are closed, the patients are asleep, or the boss isn't there, there's other ways of working. They might not be right, but we all know that that's how people work. And I do it myself. I've got a great way of circumventing the University of Nottingham's expense processes. I'm not going to tell you, but we all do it in our work. It's a normal thing to do. But if I think of a study I was involved in where it was the principal investigator, who is a geriatrician, he's a doctor, a very distinguished colleague, said to me, we should have done the social science research first, before the randomized control trial, because we'd have done a different trial with a different technology. And it might have worked, because it was a tech that didn't work. And he very kindly gives me the credit for explaining why. He knows just as well as I do. But that's something that is easy for me to say, but it's hard to do in reality, especially when you have maybe a national government who says you need to do this thing. I want to say to the minister, that's not really evidence-based. If you could give us some time and some money to work with our clinical colleagues, we could come up with something much better. The minister doesn't talk to me. I don't think he really likes to talk. He said he doesn't like to talk to doctors or nurses. That's the perfect solution, but it's not easy.
Parabéns pela apresentação, excelente. Eu tenho uma dúvida, levando em consideração até o que a Maria Luísa colocou e a Lígia a respeito de a gente estar olhando para esse processo, dessa forma de engajamento e implementação, depois de ter utilizado várias tecnologias inovadoras e tudo mais. Então, para a gente que é da área da saúde, que não estamos tão familiarizados, embora intuitivamente a gente acabe fazendo um pouco disso, mas sem método, inclusive. Como que na prática a gente consegue colocar todo esse envolvimento? Tem ferramentas específicas para isso? Tem um método que possa auxiliar, principalmente os profissionais da área da saúde que não têm essa formação no seu currículo, por exemplo?
Yeah, I mean, again, we know that a good solution is to a collaborative project with clinicians and researchers like myself, and I and my group, we love to do that. We want to work with people. It's not always possible. I think something that anybody can do is, with something new, take a little time to reflect, take some time to just consult with people informally. It may be that you'll find out some important and worthwhile things there. I know with my colleagues in the hospital in Nottingham have had a lot of success with trying to have more democratic decision making in some of their clinical areas, and it's a bit of work to get set up, but people get used to it and they find it very beneficial. So I think we can always do more in terms of participation and kind of consultation. Time is often short. We all have a huge amount of clinical work to get through, and I feel guilty suggesting to anyone that they should take more time when we know there are queues of patients to be seen. I think it might save us all some time in the long run, because you said it's frustrating when we waste our time on things that don't work. And I do think that the approach, sometimes just asking the question, how are we going to do this? Asking that question, how, it is a very powerful question on occasions, and that's the simplest thing I can think of. Is a lot of the time with the projects that I'm involved in, my colleagues who are running the trial will see something as an obstacle, a frustration to doing the trial, and I say that this is data. This is going to tell us where the problems are, and if we think about it, maybe we can overcome them, so that when the trial is finished, we've got something that will go into practice more easily. I hope. I can't promise it. I wish I could. But I keep saying that, if I could make it happen, I wouldn't be sitting here. I would have a very well-paid consultancy. And those ones you read about where they get paid £50,000 a day to swoop in and solve the problems. I'd be one of them. I'd have better clothes as well.
Boa noite. Como a gente poderia expandir essas estratégias para otimizar um programa de stewardship de antimicrobianos?
Really good question, and again, not an easy one. I think that is, as I understand it, there are issues about how people perceive the responsibility, who is responsible for what. And again, it's easy to say everyone's responsible, but this phrase probably works better in English than in Portuguese, but everyone is responsible, so no one is responsible. And I think that's often the problem that you face. I think, again, it's surprising to me sometimes that not everybody understands the consequences of, not managing antimicrobials appropriately. But the thing that persuaded me, this is just a personal experience, was I went to a talk given by, she was already a very old lady. She had been a nurse, and in the 1930s, she was a fever nurse. So her expertise was in looking after patients with fevers before there were antibiotics. And listening to her talk about her work made me think, we'll be back there if we don't. And hearing her talk about her work, admittedly at 70 years distance, she was an old lady. But I do think it's one where I think there's a wider social question, and maybe it isn't quite as serious as climate change, but it's in the top 5, maybe. Well, people don't take climate change seriously, do they? But it really is. And I wouldn't want to frighten people, but I wonder whether an approach that looked at it as a wider social phenomenon might be of help to people like yourself who are faced with the practical problems of implementation in hospitals. And I wish I had some better solutions. Maybe some of the things I've talked about of studying the problem in its local context and finding out how people understand it or don't understand it. We're doing some work at the moment about vaccination hesitancy, because it's not as simple as people just saying no. It's often, I'll take it, but I'm still worried, or I'll have one, but not 2. Which is that okay? I'm glad it's not just us. But we got a grant to study that one because I think we are now starting to understand what a very complex phenomenon it is. And again, the credit is to my colleague, Dr. Basharat Hussain, who says that we just don't know enough about the cultures and beliefs of some of our communities, particularly in big cities, and we could very well have more imaginative ways of engaging with them. He's from an ethnic minority himself, so he's great connections with his community, and he says the healthcare system doesn't get it about, it's not a principled opposition that's more complicated. I'm not sure we understand it fully, but I'm a researcher, unbiased. Saying, well, we should do more research. Give me more money to do more research. So it's never enough.
So going on to this, I somehow, não português, nós indo para essa linha, eu estou entrando numa coisa de antimicrobial stewardship na atenção primária. E a questão é, dá para usar a mídia social? Eu sempre penso, talvez seja geracional, mas eu sempre penso nela que ela é uma besta que sai correndo e eu não sei para onde ela vai. Então, se ela vai me ajudar ou se vai ser um tiro no pé. Então, a pergunta é como é que você usa a mídia social nessas coisas ou faz diagnósticos pela mídia social?
I think the thing that I am learning is that there are social media and social media and social media, and that it's used in very different ways by different communities and interest groups of people. And I'm not the person to ask about how to use it best, because I am about 40 years too old. And, my students say, did you write your essays on parchment with an ink pen? So I'm not sure I've got a very good answer to you. I would say I saw some very imaginative social media in Taiwan in the early days of COVID, run by the national government. But
It's so it's social media did go.
yeah, but they had a group of young, tech-savvy, creative people, and I think because times were desperate, the government let them run with it, and they created some, kind of quite imaginative and quite quirky. So it can be done, but yes, perhaps you and I are. But there are things old people are good at too.
No, yes, I don't know.
Tem as perguntas aqui do microfone.
Tem algumas perguntas aqui no chat. Então, a Luísa pergunta se nós devemos seguir, né, tentar de novo uma implementação que já falhou no mesmo lugar, mesmo não havendo mudanças substanciais de fatores internos ou externos, ou se a gente, por vezes, deve aceitar que aquela mudança não é possível no presente momento.
I guess the most important thing is to understand why it failed, and I guess what I've learned is what works, particularly in implementation, is so variable depending on the local context. And we've seen things that it works brilliantly on one ward, and on the ward next door, in the same hospital, with the same type of patients, miserable failure. Because, again, you all know this, every hospital ward is its own little social world, and it's like going from one country to the other. I'm sure you've all had the experience of someone saying to you, that's not how we do things here. So it could be that something that's failed in one place will work brilliantly somewhere else. I think you would need to have some reason for trying something again. It could be that it was the wrong time. It could be that, sometimes the person leading it is not the right person, and maybe someone else would have more success. I am, I'm not the person who should be leading anything, but there could be any number of factors. I think if we understand it, then in an informed and thoughtful way, maybe we can pick up something that failed and try it again. Apparently, the Wright brothers in the United States, the first powered flight, they crashed quite a lot before they got a plane to fly. So sometimes you need to persevere.
Well, you speak to the wrong audience, because in Brazil, the first powered flight is such a
I'm cultural imperialism. Yeah. Yes, it's our thing is the electric light bulb, which the Americans say was invented by Edison. No, it wasn't. It was invented by Joseph Swan, who's English. So yeah, we have our own. So, but yeah, great question, and can be worth trying again. But there's a good reason. It's not you're not always doomed.
A Carla perguntou, ela gostaria de saber qual que foi o método utilizado no estudo que foi apresentado. Eu acredito que é sobre a infecção de sítio cirúrgico, né? Que você nos mostrou. Qual que foi o método que foi utilizado nesse estudo?
Okay, good question. I kind of I went through it quickly. The original study was a fairly simple comparison of before and after, but Judith Tanner and the team, after it failed, they were so disappointed they wanted to know why. So they went back and mostly conducted interviews, kind of qualitative, semi-structured interviews, and talked to various different stakeholders about what had happened, what worked, what didn't, what the reasons were, what the kind of feeling in the the operating theatres was. So a lot of what we do in implementation research is that kind of interview focus group. We do ethnographic work from time to time. We do quite a lot of secondary analysis of minutes, notes of meetings, which sort of sound really boring and bureaucratic, but can often tell you what the argument was about, what was people's problem. And so we've been doing some secondary analysis of meetings. What an exciting life I lead. Try to understand that. And I should say that, we also do some more kind of quantitative work of looking at things like fidelity with an intervention. So as we're moving an intervention out of the laboratory, that might just be a metaphor, I don't really mean a laboratory, but into the real world, are we still doing the same thing? That can be really important. And particularly with complex interventions, do the people delivering it kind of know how to do it properly? And we tend to measure that more quantitatively. I'm a qualitative researcher. I'm not particularly good at mathematics, so I leave that to people who can count, because I'm like 1, 2, lots.
O Marcos comentou aqui que você falou de Harry Potter e a gente precisa inventar como fazer esse engajamento, né, que a gente traz em nós virar uma ação coletiva. E aí, já nesse comentário, eu emendo a pergunta que acho que foi feita aqui, não sei se saiu aqui da minha visão, mas tinha sido feita, e eu acho que é uma pergunta importante. A gente vê, quando a gente fala de engajamento dos profissionais de saúde, uma dificuldade muito maior com a equipe médica. E acho que isso é universal, né? Existe alguma estratégia específica para esse público?
I think there are the general principles probably apply. We need to be mindful of kind of who people are, what they do, how they see the world. The French have a phrase called déformation professionnelle, which is that you tend to see the world through the spectacles of your profession. And we actually find it quite hard to imagine ourselves into other people's shoes. One of the things that occurs to me, I am at business school, is if we were a commercial company who were trying to get people to buy a new product, we would have a huge sum of money to spend on promotion, marketing, and advertising. We have really talented and creative people coming up with beautiful advertisements and campaigns. And generally the things that we do to engage people, you know, not as exciting. And well, that's not our skill set, and nor should it be. But again, I kind of wonder whether we, you know, there is room for more sort of imagination and creativity in the way we go about talking about things. You know, I'm mindful that I produce the most boring genre of written texts there is, because there is nothing more dull than academic paper and underwriting. So I've kind of been struck more and more that I'm not quite sure how to do this, but I would like, I need to go and talk to some of my colleagues from fine art or film, some of those kinds of disciplines, and say, you know, how can we talk about some of these things in a way that isn't so dull? Because I'm not a creative person.
A gente devia engajar propaganda e marketing, porque não é fine arts, é propaganda e marketing. A gente devia engajar esses profissionais. É isso que você pensa.
Yeah, it would be nice if we had the money, but it could be a better way of going about it. And we tend to think that, you know, especially professionals should be, you know, above that. But I'm not sure that we are. We all buy things, so why not try it? We've with the Falls program, we have been thinking about it in a kind of marketing way, and actually we think that's beginning to work with some of the local government. They don't want a folder of documents. They want something which is engaging and lively. I'm not the person to write it, but I think it can be done. There's probably creative people with great ideas in this room. Don't know what they are yet. Maybe you.
Diante de tudo que foi colocado, me dá a entender que assim, a gente tem que criar meios para os diversos níveis profissionais que a gente tem, até de entendimento, né? Gostei muito quando você falou para a gente tentar ver com os olhos do profissional. E aí a gente controlador de infecção, a gente está muito acostumado a ver o problema e o que eu preciso, né, as estratégias para corrigir o problema. E aí a gente cria uma forma de implantar. Mas aí eu vou para uma equipe multi, né, com seus conceitos, suas vivências, e acho que o grande desafio é exatamente esse, como, às vezes, implementar um processo em vários, né, níveis profissionais, que todos tenham essa adesão, que agregue isso. E eu gostei muito da questão da avaliação do local, né, o processo da pesquisa antes da implementação, né, de avaliar o local. Eu já sei o problema que precisa ser resolvido ali, mas tentar entender o que eles entendem desse problema para tentar criar as estratégias, e talvez não seja uma única. Eu vou ter que fazer em várias etapas para poder pegar, principalmente se ela envolver toda a equipe multi. Penso que seria mais ou menos uma lógica aí de raciocínio para a gente começar a pensar.
I think you're right. someone who I learned a lot from was someone I used to work with who is an anthropologist, an ethnographer. And she said, I didn't want to go to Papua New Guinea or Timor-Leste and study people who lived in the jungle. I didn't want to live in a mud hut and get malaria. She said, then I discovered hospital, which is just as strange and just as varied and just as exotic. And again, I think she had that imagination of, she said, you know, it's just like Papua New Guinea. Every tribe in every valley is different. And they all see the world differently. And they have different languages and different beliefs. And it was, I think what I learned from her was that kind of imagination about, you know, when we see Papua New Guinea or something on TV, it looks very different and strange. Whereas these people look familiar. Actually, we're from around the world, but if we take the trouble to understand them, and we can, you know, we can all do that understanding. I think we can have some more success. I think life is made difficult for us because we inhabit bureaucratic institutions that work on universals and say everybody must do this. I might find myself thinking, Ward number 78 is a different world from Ward number 79. Maybe we can accomplish the same thing, but in a different way. I'm afraid some of my management colleagues don't want to hear that because it makes things harder for them. But I believe that's the case. So maybe it's an opportunity.
Alguém tem mais alguma pergunta? Ana, quer fazer algum comentário? Não? Bom, então, a gente agradece imensamente ao Dr. Stephen. Thank you very much. A APECIH agradece imensamente ter aceitado esse convite. Acho que foi super produtivo para nós todos. Né? A gente tem aí várias pessoas participando aí do chat. Acho que foi super útil todas as informações. E queria agradecer a presença dos que estão aqui presentes também. Muito obrigada.
Muito obrigada também à mesa, as discussões, Stephen, obrigada mais uma vez. Para quem está conectado, pessoal, obrigada pela presença, pela contribuição de cada um de vocês. Peço desculpas pelos problemas técnicos do início, né, mas deu tudo certo. E quero agradecer mais uma vez a CNPH, né, os nossos patrocinadores. O Randolfo está pedindo para eu ir na frente. Desculpa, não estou aí. Vamos dividir aqui. Então, agradeço a CNPH, nosso patrocinador desse evento, também o Hospital Samaritano e Higienópolis, e mais uma vez a presença de cada um de vocês. Então, nós nos vemos, talvez virtualmente ou pessoalmente, no próximo Debatendo com a APECIH, e quero lembrar que a gente tem, né, no próximo dia 28, né, Fabi, o lançamento da monografia de imunossuprimido, então você está convidado, vocês estão convidados a participar desse evento bastante importante. A monografia ficou excelente, é um conteúdo imperdível, então estejam conosco no próximo dia 28. Tá? Então, agradeço mais uma vez a presença de cada um de vocês e a gente encerra esse Debatendo com a APECIH. Agradeço mais uma vez a presença do Stephen e a colaboração da professora Ana Sara e a professora doutora Malu Moura. Obrigada, pessoal. Boa noite.